So listen, this is one of those times when as a father you're quite proud. I know this is going to embarrass Kristen a little bit, but all of my daughters, of which Penny and I, my wife who's out and about, gave them an attitude where hopefully they would follow some form of academic excellence. And two of our daughters are, one is a dentist, one's a dental student. Kristen went a little different route, and Kristen is a physician assistant at a West Virginia University clinic in Harper's Ferry, and she specifically deals with pediatrics in young people. And when I put this presentation together, it was to not only provide to you what my new thoughts are, but also Kristen gives me an access to data at the university in a clinic, which deals with what you'll see in a moment is important patient population. So about a third of this is my idea, and about a third of it is Kristen's work, and it's sort of nice to be able to present a collaboration, if you will, a co-author with my daughter. This is the first time she's co-authored with me. My other daughter, one of them has, but this is her first time seeing her father. No, she has seen her father perform before, but being able to present her data, I think, is kind of cool. So she's a little nervous. If you see her, please tell her that she's just part of the team. That's what we do. So listen, what I'm going to do, I hope you'll like this idea. I hope that it will be apparent. I think one of the things I've been able to bring to microbiology and the university is little thoughts out of the box, not being the standard scientist. I think a lot about what I do. I run a lot. I ski a lot, which by nature are sports that are quiet, by yourself. Gives me time to think. I'm running a half marathon next Saturday at Antietam Battlefield, which I'm going to run with my son-in-law, and he's going to be done, showered, and have dinner before I finish up. But that's okay. I'll be running the 13 miles on hopefully Saturday next week. And this came upon me as I was running, actually a couple of years ago. I wanted to organize microbiology and particularly chronic diseases into a simple way of teaching, but also into a way which made sense with the new things we know about microbiota. So when I went to put this together, I talked to Kristen because she had access to the patient population. And also at the clinic that she is at, the Harper's Ferry Medical Clinic, there is a PharmD who has also been very helpful in putting this data together and giving me information that is a beginning, but certainly a long way from being finished. So I know we talked about Buster earlier, probiotics. I brought down Antibiotic Witchy. She's my favorite because she's the biggest puppet that I have, actually. And I'm going to talk a bit more about antibiotics today and some resistance issues, as Dr. Brook did before. So let me kind of go through this. So clocks, how many clocks do you know? You know, and I keep thinking about there are all kinds of clocks, but there's biologic clocks, there's clocks that are associated with chemical reactions, there are clocks that are circadian clocks, right? How many of you ever thought about a microbial clock? And so I began to think a bit about that, and I said to myself, when the microbiota data from the human microbiome study became available in 2007, there are, if you look at databases on certain kinds of patient populations, and you look for certain kinds of phyla, you find a periodicity. And I began to think about the periodicity of various diseases and of the organisms that are associated. This really puts together 2 points that I'd like you to be able to see. And one is, when the human microbiome study became apparent, we could identify there's approximately 10,000 species that we are partners with, my dual citizenship. In a clinical lab, we couldn't possibly report 10,000 microbes. One of the things that became apparent and where we are now going is to report individual organisms perhaps, but individual organisms in the family microbiology trees might better be associated with certain phyla, families, phyla, a cluster of genera that may share common features, but rather than looking at individual microbes and kind of get lost, let's put those microbes into clusters and let's look at them as what's reported in the national studies in 2007 of phyla. And in fact, if you take the 10,000 species that we cohabitate with, there are about 6 phyla that represent a cohesiveness of those 10,000 microbes. And we begin to hear these names, and we begin to see that if you cluster these names and look at periodicity, there are certain repeating timeline presentations of certain phyla. And I began to think about that, and again, when I was running, I said, gee, it's kind of like I ought to be able to do something with that information. So that was one thought that became a germ in my mind. And the other was, along at this same time as reviews began to be published, and again, certain heat maps and presentations of certain phyla and of certain genetic propositions through them, the reality was that no matter what these names are, there was within normal patients and in diseased patients some periodicity. And I kept thinking about that, and I kept looking up what things might be and what would make me interested in carrying this forward. The information started to come together. I'm a professor at the dental school. We talk about periodicity of microbes in the oral flora. On genitalia, particularly in women, there's a periodicity of certain microbes. I began to think about the skins and the wounds that I showed you this morning. And I began to think that, there's more to this shift than I thought about. And I thought I could make something rather important. I thought a long time about this, and now it's beginning to come to fruition. And it's beginning to have some value, not only in teaching, but also recognizing that there is a microbial clock. And I organized it in the following way. I said, well, listen, let's look at some time frames that might have relevance to disease. And I went to the NIH and I went to the World Health Organization, maps and charts and dates. And basically, we can, if you will bear with me, this very simplistic approach, divide our life into sort of four time frames. 0 to about 12 years, 12 to about 18, 18 to 55, and then greater than 55. Simple. Then I began to layer on that time frame the diseases that particularly are associated with recently published information that says that these diseases have some link, maybe not causative yet, but clearly a population of microbes out of these patients from selected sources, not always GI, but other sources, can be associated, if you look at a control population, that autistic patients, asthma patients, where Kristen is in a clinic, maybe there's something to be said about this shift, and we could predict their outcomes more readily with the very difficult clinical scenario if we knew what their microbiota defined by phyla groups would be. And I could spend hours going through the amount of time it began to take looking at each of these diseases, looking at them, as you already know, in West Virginia, where diabetes and obesity is a huge, no pun intended, that was so bad, a very large, that's still bad, where diabetes and obesity is high on the agenda. And then if you look at the ages where middle age would be associated, you begin to look at the gut, the vaginal flora, diseases associated with osteoporosis. If we look at certain cancers, particularly in men, in colorectal cancer, and then if we look at patients who are on the more advanced age, now remember, I'm 73, so I'm in this block, and that is not old, that is aged is the word that we're supposed to use. So please, I'm not old, I'm aged. But if you begin to look at these diseases, particularly associated with dementia, and you look at the data that's beginning to be accumulated in each of these windows, associated not with the microbiology by historic means, but by rather phyla and changes over time, one can begin to see that in fact there is a periodicity and a time frame in which some of these diseases begin to show in the clinical sense. And I spent quite a bit of time in the preliminary sense, and I came up essentially with 12 chronic diseases in which there's a fair amount of now published data which says that this is associated with some very shifts in phyla, but as you'll see in a moment when I present Kristen's accumulated information, it would appear that very early in life, think about this, why is in history the most reasonable method of birth a vaginal delivery? I was at a very large probiotic meeting in San Antonio. Very famous obstetrician got up and said, "So, why are babies born head first?" I mean, we could sit here for a week discussing that. He said, babies are born head first because the first external option of the microbial acquisition is mother's fecal flora. That is terribly, terribly important. The route of acquisition of normal flora is defined by a procedure which is in history of all of us. Babies before cesarean sections were born head first. That's not by accident. According to this obstetrician from Johns Hopkins, it is because that is the way microbes gain access and why vaginal delivery is a preferred method to cesarean section relative to the microbiota. I had never heard that. I just never thought of that. No one had ever said to me that vaginal delivery is a better microbial support vehicle for a newborn that is a cesarean. And as I began to look at the data, I'll come back to this in a moment, what is the difference in patients who have these situations in this early life? Because here's the other way to look at that. We can have diseases that are associated with time frames, and I had to come up with another way of sort of segregating them. So I said, all right, we'll call this the green, more often not as dramatic perhaps as those that are yellow, those that are orange, and then ultimately those that are the red diseases, because, I didn't realize this, some organisms that are acquired from mother are very helpful, but becomes more and more of a problem with age. Same microbe, different place, but a different disease. So we have two problems. How you acquire your normal flora, that's the old term, you can tell my age, what we used to call normal flora. How do you acquire your microbiota defines that microbiota. And then how that microbiota works with your system through your life will define certain other diseases. And I'll show you what those are. So in the United States, the average age of the population is 37.5. That's kind of an interesting number. But the reality was I began to look at this from an economic point of view. And if you look at the population that's in each of those categories, this is a huge problem for people my age, where microbes that were acquired in early life have the potential to cause significant problems because of the organism diversity. And the diversity is measured by phyla, not by individual names. So I sat down and I began to look at these published reports, and this is what's beginning to happen. That in those diseases early in life, where particularly just a moment ago we're talking about and we'll pursue autism and asthma, the proteobacteria phyla is the preeminent phyla. It's not, there's the 6 phyla, but in this population, this seems to be a major issue. A shift from the diversity of the microbial balance to a single phyla, which is abundant beyond whatever it would be in a non-asthmatic or non-asthma patient. Surprising. When I began to look at other problems leading to the adolescent era, the series of, again, phyla which began to shift in those that were preeminently qualified, if you will, for disease. When we got into West Virginia, we found 2 phyla, not we, the published literature, found 2 phyla that were preeminent in close but not exactly the same in obesity and diabetes. The Firmicutes for sure in obesity. Those patients in West Virginia who are obese at a very young age have a preeminence in the stool flora of the Firmicutes. That's a very interesting fact. Now, why is that? I'm going to give you another one of my little sage comments. You are not what you eat, you are what your bugs eat. Now hear me, that's a very, very important statement. You are not what you eat, you are what your bugs eat. And in essence, what that is saying is the carbohydrate or food input that is used by the population defined by phyla is that population which then produces byproducts like short-chain fatty acids. Short-chain fatty acids are a link to obesity. We know that. Where do these short-chain fatty acids come from? They come from a population better defined by phyla that is preeminent in Firmicutes. I'm a thin person, always been relatively thin my whole life. I would, by this definition, sort of eschew that I don't have a lot of the phyla in the organisms that are associated with Firmicutes. Where did these come from? Was this a vaginal delivery or a cesarean delivery? And what's their lifestyle later? And so you continue down this road, and we have found, particularly in women who have osteoporosis now, there's an association with the actinobacteria, and maybe some of the bacteroidetes, but again, we can define who we are associated with a clock by an overpopulation or underpopulation of a particular group of microbes better defined by phyla. And ladies and gentlemen, you better get used to this, because tomorrow when I talk about the laboratory in clinical medicine, we're going to be reporting phyla, because that's where it's at. That's where good, I'm not going to say E. coli, I'm not going to say Staph aureus, I'm not going to say Pseudomonas, I'm not going to say Stenotrophomonas multifila. I'm going to say these organisms as part of this phyla, because that's where now clinical microbiology is going. Because we have the potential, with all of the instruments that we now have, our lab's going to identify microbes by mass spec, mass spectrophotometry. I will identify every organism you give me a specimen that I can find. I don't need it to grow. I don't need it to be viable in a medium. I'm going to do mass spec. How do I report out 10,000 organisms? I can't. Nobody will interpret that. So we're going to be clinically doing this kind of scenario. And so one of the things that's beginning to arise is part of diabetes management is going to be fecal flora. Recognition that it's not what you eat, it's what your bugs eat that contributes as a cofactor to some of these very chronic diseases. And I'm putting this in simplistic terms, but it's where it's at. Here's the other part of what I think I've sort of stumbled upon, and I didn't even think about this until a little while later. Most of the diseases that I had listed earlier on are diseases that are defined by age. And the population shift is defined at that age group. One of the organisms which in dental school is very interesting is Fusobacterium nucleatum. Very common oral flora. You acquire it by vaginal delivery very early in life, like day 0. This microbe at day 0 in the colon of a newborn is a friendly microbe. By the time that microbe begins to be influenced by other things, including your lifestyle, it begins to be a real player, and guess what here? Same microbe, but now it's part of a different pool, and it's the major cause of periodontal disease. Perio in West Virginia is huge. We have people who come into our clinic, and I've said to my daughter, one a dental student, one a dentist, how do you extract patients' teeth who have essentially no gums or no bone structure? She said, Dad, I reach in and pull it out because there's no structure to hold the tooth in place. That periodontal disease is associated with the exact same population that was very friendly when you're here. And most recently, Fusobacterium nucleatum in colorectal cancer in men is the most commonly associated change in the flora of men who have colorectal cancer. It's Fusobacterium nucleatum. It doesn't say it's the cause, but it surely says it's an association. And so now we have two clocks. We have a clock which defines the diseases we've already described, and we have a clock that defines the time that the same organism over time becomes less of a friend and more of an issue. So what are these factors that change this a bit? And we don't have time. And how much, Vic, how much time do I have? Because I could talk for hours, as you know.
You have 7 minutes, and that includes questions.
Okay, well, no questions. I'll talk 7 minutes. So I began to, yeah, you know me. I don't want to. So I began to think about multi-drug resistance and what Dr. Burke has been talking about, and antibiotics. Antibiotics have recently associated with chronic disease, highlighting aging in a microbial clock. Newborn and childhood diseases, asthma and autism, particularly are untoward consequences. In adolescents, mounting studies of diabetes and obesity highlight antibiotics as suggested cofactors, amplifiers, or precipitators, and should be used only when value of therapy has been validated. For the aged, antibiotics are potential cofactors in colorectal and certain kinds of stomach cancer. Folks, we all take antibiotics like it's water. Antibiotics in the stool flora measured by phyla and shifts in population are disaster for us. You should never, in the population of microbiota, take an antibiotic without some reason. And yet, we do, all the time. So I made that up. I didn't make that up. It led me then to say, what can Kristen help me with? And as I said to you, Kristen is at a clinic, which, as I'm going to show you, has a few pieces that will be very helpful. And I said, so Kristen, let's look at two of these diseases which today are high on the agenda of interest to the public. We'll look at asthma and we'll look at autism. And just to start, we'll start looking at medical records of the numbers that you see listed there. And the reality was Kristen's environment, and like you so well did this morning, the reality is we're at Kristen's clinic at Harper's Ferry, a very famous place in the United States history with the Civil War. About 60,000 people. The clinic is a rural health clinic. It is affiliated with WVU, which is West Virginia University. And there are 10 faculty providers, 8 are physicians, 2 are what are called mid-level, or like Kristen, a physician assistant. And then there is quite an influx of residents, so you have essentially 25 medically trained people dealing with about 150 visits per day, and about a third of those are pediatrics. And that's where Kristen comes in. She sees a lot of those that have the potential of being diagnosed as asthmatics, autism, and obviously a variety of other things. What we used and what I asked Kristen to do is to begin to give me some data. She could get the medical records, but you find out when you do research some of the limitations of your research. They went to electronic medical records in 2009, and so a lot of this data is very hard to come by. You know what else you find out? Is how poor people put records into chart review. You'd like to think when we defined what 12 characteristics we wanted to measure, what would be on every patient's chart, and Kristen can tell you much better than I, less than half of them would have all the information we wanted. I mean, medical records is great if the physician or the mid-level puts in the information to the chart, but otherwise we're sort of out of luck. So what we found out very early in this initial presentation was we had quite, and I say we, Kristen had quite a few medical records that gave us information on 40 of our first 50 patients that were associated with asthma. Kristen could only find 9 that were autism associated, and they had very poor record keeping. And that's one of the things you do research. You start, and I said to Kristen, don't be discouraged. You start these studies, and you find out what the limitations are. And what we found out in just the last 3 weeks was, in essence, the difference between, again, here's the point in what I think I wanted to say up here, is when we were looking at asthma and autism, we ultimately found out we have much more information on asthma, because autism, as I'm learning from Kristen, is such a medically hard to define disease. And because there are so few certified physicians who can actually do that. And in the state of West Virginia, am I going to say this right, Kristen? There's only one person in the whole state of West Virginia who can make that clinical diagnosis. Because once you're labeled autistic, that sticks with you for your life. So Kristen found that there is just a limited amount of information here at this moment. On the other hand, what we could do is we wanted to find out how many were born cesarean, how many were born vaginally, and either category, how many had antibiotics, because you already now know how I feel about the use of antibiotics. And at this level, this, as I wrote down there, I should have made this 3D and ongoing. This is just starting, but we've got to start somewhere. That's what research is about. And so we have found that basically we looked at the 50 patients, of which 40 had essentially the information we were looking for. 10 of the asthma patients were C-section, 30 were vaginal. And of those 10 C-sections, 7 had antibiotics. And out of the 30, 24. So it turns out that if you look at the delivery method and the amount of antibiotics given throughout the time of diagnosis, it's about the same, which in my mind is pretty interesting. We looked at the number of visits that were made before the diagnosis of an asthmatic was made. They're about the same. And one of the questions that we've asked of our 12 questions was, how many of them had a preceding history, a family history, and about half an equal. So at this moment, without a control arm and still a very almost non-existent limited information on the autism side, we're just starting. But the key here for me is that this is a disease associated with flora of the gut that is acquired from the mother, and that I think that the difference will be, the hypothesis is that a child born vaginally without the use of antibiotics will have a significantly lower probability of developing either asthma or autism. That's our hypothesis. So this is that point of view that I also like. Vic, I'm done. I promise you. I was reading an awful lot of articles. Do you know what it said? A mother delivers twice. Think about this. A mother delivers twice. One, the fetus. Secondly, the microbial flora of the newborn. That's the second part of the delivery. And I see you looking, I never thought of that, but that's a very serious observation. Cesarean section, you know where the primary flora comes of the newborn? From the healthcare providers. So you are beginning to see a very separate, and who are healthcare providers? So this is an area which I think has tremendous future, and I kind of wanted to throw in here, because I'm bringing this to conclusion, there is a very famous infectious disease physician who's in Boston, Stuart Levy, a very good friend of mine, and I loved, in 2002, what did he say about antibiotics? We began the antibiotic era with a full-fledged attack on bacteria. It was a battle misconceived and in which we cannot be the winner. We cannot destroy the microbial world, and we evolved. And the second part of what he said is we need to forget, overcome, and conquer, and substitute peace when regarding the microbial world. This is said in 2002. This is the crux of my presentation, and also why I think probiotics, or called therapeutic bacteria, will have a very strong influence in the future. And what I think we want to look at when we look at these diseases, remember two things. If we measure the diseases in a clock and begin to position them relative to the fecal flora and skin flora and oral flora of the phyla-defined microbiota, what's going to happen as we live longer? Where's that microbiota going to come from? And one of the issues, Time magazine, not my favorite magazine, but it had an article that most of the children born today will have the potential of living to 142. Now, if we define the microbiota in these chronic diseases, what's it going to be in this population? Very, very interesting thought to me. When I'm 141 and we come back here at a meeting, how am I getting my older microbiota? And I don't know that answer. So I think these are the things we need to think about, and I'm going to end right here because I think time at this level is sort of against us. But one of the things our poster will have, and they're going to be out here tomorrow, I'm told, out here, is we need to be addressing microbes on the conditions that will favor the kind of use that is tagged to a clock. And we've got to start rethinking how important this microbiota is here. And you know what I want to say, in which we had sort of addressed here? The microbiota is your training center. It trains your cells. It trains your brain. It trains your immune system. So to not realize how important that is a mistake. And I leave you with this because I still think this is an enormously important growing feature. But as I said to you, I finally wrote this down. I begin every lecture to my students. We live in a microbial world. It is their world that we must learn to be comfortable with. It's a genetic world. It's genes, strength, but that's why I think looking at chronic diseases, looking at the change in the phyla, and then being able to manage them not with antibiotics, but with probiotics is where the future of good healthcare will be. Thank you very much. Oh, and I got to say, I just want to publicly thank my daughter, Kristen, for doing the work, getting the data, and then telling me one day, you know how when your daughter calls you, Dad, 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 she thought she had lost 5 hours of work. She had not saved all of the numbers from chart review, and she was not a very happy camper, to say the least. But Kristen, I thank you very much.